And now we invite the next speaker. She is Dr. Mukta Sharma from WHO Southeast Asia and will deliver a global collaboration for anti-TB strategy. I invite Dr. Sharma to come. Let me read your curriculum vitae first. Dr. Sharma, Mukta Sharma. He was a regional advisor for TB in WHO SHARE and team lead for a communicable
was published from 2015 onwards till today, we have seen huge transformation in the overall availability of diagnostics. There are 12 new diagnostic tests that are available for TB, which WHO has approved. We have the most exciting thing happening about 6 months ago, when we found that now you can treat drug-sensitive TB, uncomplicated TB, in 4 months. Not in 6 months, in 4 months. Ladies and gentlemen, think about that from the perspective of someone who has TB. They have to take treatment only for 4 months. Think about it from the perspective of your BPJS. They only have to pay for 4 months. So this is a massive development. Even more, we now have treatment for complicated multi-drug resistant TB in 6 months. Can you believe that? In 6 months. When I first started working in TB, This treatment went on for 2 years, 3 years. We had a success rate of 30%. Now we are talking about success rates of 80%, 90%. There was a time when I was working in Thailand for multi-drug resistant TB, pre-XDR. We were paying $40,000 per patient for a treatment course. Can you believe that? $40,000. Today, that has completely changed. Even more, we have fabulous new treatments to treat TB infection. It's very important to understand that we will not eliminate TB unless we really manage to end TB infection. There are 10 million of us who get TB disease every year. There are 3 billion of us who are living with TB infection. And unless we can really figure out who is infected with TB, will progress to TB disease, and treat them, we will not end TB. Now we can treat TB infection with new drugs. You all have heard of 1-HP, which is rifampicin based treatment for 1 month daily. You've also heard of 3-HP, which is again rifampicin based treatment given 12 times, once a week. So there is really a lot that is happening in terms of diagnosing TB treatment, in terms of diagnosing TB, in terms of diagnosing infection, and as well as in treatment. But the most important thing, and which is the most exciting potentially for us, at the moment there are 14 TB vaccines which are in various stages of development. And the most exciting is the M72 AS01E vaccine, which has shown up to a 50% efficacy. 50% efficacy will make a huge difference. Remember when they were talking about the COVID vaccine? And at that time, people were saying, if we get a vaccine that is 50% efficacious, that is good. That is good to go. We are almost there in TB. And at the moment, there are 4 vaccines which are in phase 3 clinical trials. Next, please. Next, please. So as I mentioned already, 25 new treatments, 14 new vaccines in various stages of clinical development. And how quickly we are able to get regulatory approval, how quickly we are able to register those treatments and vaccines in countries, how quickly we can get health insurance to pay for them, how quickly we can get them to the Puskesmas level, to the primary healthcare level, how well we maintain our supply chain and our logistics is what is going to make the difference between development and impact. Next, please. So you can't really see this slide, and even I can't see it with my glasses on, but I've listed for you all the various TB treatments. And what is interesting here is we have almost 15 new molecules. These are not repurposed molecules only. We have new molecules, and we have repurposed molecules, and often we are using a combination of them. You may all have heard of BPAL, where we had a new molecule, then Protomidid, which was then used with other drugs to give you a much shorter regimen for MDR and pre-XDR. Next, please. Again, not for you to focus on. You have this information available in your slides. These are all the drugs and drug regimens that I was talking about. Next, please. Now, I want to take 1 minute to talk about this slide. These are the drugs that are not for TB disease treatment. These are the drugs that are evolving for TB infection treatment. And if you look at the right side, you can see what is available in phase 3. And there are multiple trials going on. And you will be seeing the results of these trials very soon. There's the TB Champion trial, there's the WIP3 TB trial, and many of these are also focusing on the use of 3-HP in people living with HIV, without HIV. What is the impact of some of these drugs on the other drugs that are being taken by people living with HIV? For example, now some of you may know that the drugs for HIV treatment have changed. The global standard now is using dolutegravir, and we want to know how 3-HP is interacting with that. So lots of work also happening in treatments for treating TB infection. Next, please. And this is what I was talking about in terms of the vaccines. As you can see, there are 14 vaccines out there, but the ones that I really want to highlight for you are in the third column. I already mentioned the M72, but we are also looking at repurposing the existing BCG vaccination. And there are very interesting trials going on about that. In the past, the BCG vaccine was only given to children, but now we are thinking, could we revaccinate adults with this? Could we focus on the elderly, for example, with the BCG repurposed vaccine? Why am I saying elderly? We are a rapidly aging world. In a country like Thailand, more than 50% of all TB case notifications are in people over the age of 50. Similarly, Sri Lanka. So the face of TB is rapidly going to be older men, because that is really where most of TB is sitting in most countries, from Japan to Southeast Asia. In Indonesia, that is not the case yet, but slowly and steadily you will see. And my colleague earlier was mentioning that even in Tangerang, when you did TB case finding, you found 22 out of 1,000. That's a very high rate. So we really need to be thinking about how do we address TB in this group. And one way to do it is to revaccinate. Another way to do it is to think about, can we be using preventive therapy in the elderly? How do we deal with potential hepatotoxicity? How do we deal with using preventive therapy for diabetics? A big population. And in Indonesia, a huge overlap between NCDs, diabetics, smoking, obesity and undernourishment. Can we be thinking about using preventive therapy at a larger scale in that population? These are some of the questions that are being considered. Next, please. Next, please. Okay, so I've told you a little bit about what is happening. What are some of the new exciting developments? But I want to consolidate for you what are the key research gaps in TB. Where do we need new researchers to come forward? And what are the questions we want you to focus on from a WHO public health perspective? The first is clearly the vaccination. Vaccines are going to make the difference of whether we have an incidence decline of 5% per year, 10% per year, or 17% per year. The second is, even though there is a lot of new technology for diagnostics, we are still missing that simple, really cheap, easy to use point of care diagnostic test that can be done at the Puskesmas that doesn't cost $20. That is something that we are still missing. We really still need that test. The other thing you need is figuring out tests for TB infection. We cannot go and give everybody in the world who has TB infection 1-HP or 3-HP. We cannot take an IGRA test to 3 billion people. We really have to see, unless we have a test where we can rapidly say, this is a person who has TB infection and will transition to disease, and we want to focus our effort on treating this person, that is the test we are still missing. So we need rapid, cheap point-of-care diagnostics to diagnose TB disease, to diagnose TB infection, so that we can focus our treatments, our strategies on this group. We, of course, need shorter regimens. While I told you the good news earlier about BPAL and other drugs being available for 6 months and for drug-sensitive TB for 4 months, that is still a very long treatment. And what's very exciting is currently we are looking at clinical trials where we're thinking about drug-sensitive TB completed in 2 months. That's very exciting, isn't it? 2 months. So that's something which is also a critical research gap. So next, please. So now that we've highlighted what are some of the key research gaps, we at WHO also are consolidating all of the research gaps from the guidelines. Every time WHO does a guideline development group meets, and we have a grade process for looking at the evidence. Sometimes they're not able to make strong recommendations because the quality of the evidence is not strong enough, or there is missing evidence. So we have consolidated from all of our TB guidelines where we have the biggest gaps, and I want to share those with you. Next, please. Okay, so from all of the WHO guidelines, we had nearly 240 research gaps. What's very interesting is most of these gaps, nearly half of these gaps, are in implementation research, answering the question of, is it acceptable? How do we manage equity? How feasible is it? What is it going to cost? How efficacious is it in operational settings? Now, this is very interesting because earlier Bapak Mantri was talking about the Global Fund. And we've also talked about always how there is such a lack of funding for research, for TB research. The Global Fund will not pay for basic science research, but they will pay for operational research. And I think we should always be thinking, when we are writing Global Fund proposals or talking to the Global Fund, how can we address these gaps, the operational implementation science gaps? Of course, that does not mean that we don't need more clinical research, which clearly we do, as I said, for the tests, the rapid point of care tests and the vaccines. But a lot of the research, for example, off the top of my head, how do we roll out smoking cessation in TB clinics? What are the medications that we can offer for smoking cessation to a TB patient? How do we get a mother who has a child who does not have TB, but she has TB? How do we get that mother to start preventive therapy for her child? How is she making those decisions? Do we understand that in the TB community? Not really, because we say, here is the drug, here is the test, do it. We only focus on supply side, but there is always a demand side, and we need to understand that, particularly through implementation research. So to summarize this, implementation research is something that can be done. It's not very expensive. It can be done by all of you in your hospitals, in your projects, and as long as that information is consolidated, reviewed, this can make a huge difference to the way evidence is used in countries. Next, please. At WHO, we have something called the TDR, which is the special program on research in tropical diseases. Now, TB is no longer just a tropical disease, but this is an old name. And TDR works with many governments and the national TB programs to focus on operational research. And one example is the short TB research, which has been focusing on drug-resistant TB, shorter regimens for drug-resistant TB. But they also do the sorted courses. For example, you've seen them with the Union, the typical operational research courses that are supported by there. Next, please. And these are some of the global partnerships. I think there is some sense now globally that research and development has been lagging, and individual efforts only at the country level will not be enough. So you need partnerships to come together. And I've highlighted for you two big ones. The first is Unite for TB, which is an initiative of the European Union, the Innovative Medicines Initiative, and it's part of the European Federation of Pharmaceutical Industries Associations. And then we have the Pan-TB collaboration. This is really largely led by the Bill and Melinda Gates Foundation and many other public health-minded pharmaceutical providers. We're looking at GSK, we're looking at Johnson & Johnson, Otsuka. My colleague Masudara is here from Otsuka, who's also focusing on global health. So these are thinking about bringing together concepts which can very quickly then go into phase 2 and phase 3 trials. Next, please. I want to say a few words about what that could mean for Indonesia. So Indonesia has a TB research gap list. Many countries have a focus on the TB agenda, what that means. And I think this list should be updated regularly, focusing on the demand side and the operational side as well. Next, please. Okay, so trying to draw lessons from the 4 areas of the global TB research strategy. What are the 4 areas of that strategy? The first is create an enabling environment for research, support research. Many people, many academics don't have time to do research. We need to create that time for research. Find ways of funding TB research. Funding is critical. The other really important strategy that we are pushing for at WHO is data sharing. Now, this becomes a very difficult issue in many places because people who are doing research want to publish it. Publication can take 1 or 2 years. And often the research is done in one part of the country, but the national TB program does not benefit from the research that has been done in that country. We also find that when we are doing guidelines at the global level in Geneva, sometimes we don't have enough of a sample size because so sharing data is critical to research, is critical to good guidelines, and having a key way to share data within the country and globally is really very important. And lastly, not all countries have the same research capacity. Countries are different in their capacity. For example, you look at a small country like the Maldives, we cannot expect the Maldives to be doing clinical research, basic science research, but the Maldives should also benefit as quickly as other countries that are doing the research. Sharing research, making it available to those countries is a key strategy. We can apply all of those 4 strategies to the situation in Indonesia. And Indonesia can rapidly advance in innovations if domestic funding is available, if data sharing is done, and the findings of the research are shared by the program and quickly translated into what is funded by health insurance. Next, please. This is just the global gap in funding. The requirement is 2 billion. We are at 901 million. And so you can see that this funding can only come from domestic resources in middle-income countries, in high-income countries. There is a need to really put much, much more money into TB research. Next, please. So in Indonesia, Indonesia has the presidency of the G20. You all know from the traffic jams outside that that the summit will be held in November. We are widening roads for that. There was a side event that was done on TB, and under the focus of the direction that was given to us from Bapak Mantri, there are really four things that we were trying to achieve here. One was to advocate for TB at the highest level. The second was to advocate that within the G20 countries, there should be much more funding available for TB research. And the mechanisms for this can be bilateral, can be multilateral, or domestic funding. Secondly, there is a call to action document, which we were pushing for. And this call to action document goes to all of the ministers of the G20 and will also possibly be reflected in the declaration of the summit. And here again, we are pushing for rapid investment. Additionally, we are talking about sharing of manufacturing. Indonesia, for example, has large manufacturing capacity, and Indonesia can very a couple of years ago, which showed how cost-effective TB interventions are. And for every $907 that are invested in TB, you gain $38,594 plus 20 years of life. That is one of the most effective public health interventions. So investment sustainably is what we need in research. Next, please. So I'm going to summarize now so that we can all go and have our lunch and say that Indonesia can initiate and participate in research activities. There is a lot of capacity here and a lot of leadership in the academic area. Secondly, Indonesia can be pushing for all of you, advocating for funding, additional funding for TB research, and the Global Fund is just one opportunity. The opportunities that the union provides with its sorted courses is another opportunity. We should really be taking every opportunity for funding that is available to us. We also need to consider a very large private sector. And unless there is a conducive environment to work with the private sector, we cannot have them as partners in research and in implementation and in ending TB. So how we work with the private sector, whether it is through a public-private partnership forum, whether it's through an institution, is something that all of us need to understand if we are going to push sustainably for their involvement in TB research and innovation. And finally, the TB research agenda should be routinely updated. We should all be thinking of the most important questions for Indonesia, and focusing on prioritizing those top questions. So with that, ladies and gentlemen, terima kasih. Thank you for your attention.
Thank you very much, ma'am. It's very nice presentations. Give us some new knowledge. But maybe someone want to raise a hand and asking question, please.
I think the question everybody will ask you is, where is lunch?
Okay, Ibu. Silakan, Ibu.
Okay, thank you. My name is Leila Ranasari. I am from MPKU, Parliamentary TV, Muhammadiyah, PP Muhammadiyah. Just simple questions because it's already lunchtime. We are just considering about the challenge in Indonesia that we know we still have some challenges in our some of our hospitals, that people still worried about to do the preventive therapy. Like some of the reason because they feel health, why they should drink a medicine, and also for the parents, for the child's preventive therapy, the parents still worried about the drug effect of the medicine. So what your suggest to overcome this problem, this challenge? Thank you.
Okay, about the treatment. Someone else, maybe? Silakan Ibu. And also Bapak, but Ibu first.
Selamat siang, Dr. Sarma. I'm Esti. Saya dari Stikes Kuningan, and I'm also the representative from the community. So thanks for sharing with us a very exciting and promising innovation regarding the TB, include the treatment, preventive treatment, and also vaccine. But I'm just thinking that since when you share with us, it show us it's quite long process before the action, because there is the phase to do the innovation and the research and then the action. So from the community, we really wait this the innovation. So whether you can share with us about the clear timeline when it will be the action. Thank you.
Okay. And the last one, sir, please. Okay.
Computer scientist. At this time, I developed an AI, artificial intelligence-based detection system for pneumonia. I'm very excited to hear a commentary from you regarding the system detection. That recently, maybe we hear quite a lot. Yes, for detection system using AI. Do you have any commentary or suggestion, etc., for us, especially people who work on artificial intelligence? Thank you so much.
Okay, I think it's clear for you. And then, please.
Thank you very much. And it's very nice to see you again, Ibu Esti. It's been a long time. We work with Ibu Esti quite a lot in WHO, in the regional office, as well as globally. She's a globally known advocate for TB, and I'm very happy to see you again. So maybe your question first back. Artificial intelligence is a key research area and is a very, very important way in which people are taking rapid diagnostics to the field. And even in the diagnostics I was showing you, there is an entire section on artificial intelligence. There are several players, and I think the important thing really is, how do you make it cost effective? And how do you make sure that it can be used? That is, the usability of it is very, very important. Now, artificial intelligence is much easier to deal with than looking at a chest X-ray, where you need a radiologist to look at it. Artificial intelligence can be a much more simple algorithm-based approach to it. So we at WHO, I think this is a very exciting area, and I'm not an expert in this area, but I can certainly say that if you are doing some research on that for pneumonia, you should certainly be able to extend that for TB. In fact, you often see TB in people who we think have pneumonia. So, that kind of approach to be able to detect pneumonia and respiratory infections and TB is a very important area of work for artificial intelligence. So that's my only comment right now. I can help put you in touch with some of the other research that is being done in this area, and then we can talk more about that. So I'll go to Ibu Esti's question. I think, Ibu, I think we all share the frustration for how long it takes for research to start and then to really, make a difference for people. And to give you a very simple example, you remember smallpox? The smallpox vaccine was first, a person called Jenner worked on it. I think it was in 1806 that they started doing work on the smallpox vaccine. But it was only in 1974 or 75 that we eliminated. And this really brings us to the point. Technology existing is not the same as technology being used in the right place at the right time. At the same time, you've seen that with COVID, suddenly we were able to deploy technology, we were able to deploy vaccinations, we were able to create a vaccine within a year. So it is possible to do it. But streamlining those processes and bringing together all of the people who are involved is very important. Often these are not people in the health sector. If you think about who needs to be here, it's the FDA that needs to be here. And what are the FDA processes and how simple are they and how can a manufacturer apply is something which is different in different countries. In the UK, which is a country I know best, we were able to very, very quickly, the Medicine Regulatory Health Products Agency, within 2 weeks, we were able to say the vaccine is here, we are going to use it. In India, which is another country I know slightly more, that wasn't the same. So that is a country-specific issue. And we need to be able to say, who are the players that need to be around the table? And as I said, it's often the ministries of finance, the FDA, the Ministry of Commerce. We need to be bringing them to the table for this. So I share your frustration, but I can't share a timeline because I see that the timeline varies from country to country. And we should all be advocating for a faster, quicker timeline. The last question was about how do we address patient resistance, for preventive therapy, et cetera. I don't really have the answer, but we know that wherever you have focused patient communication, wherever you have focused patient interventions and counseling, you are likely to see many, many more people accepting treatment. It's very hard, if you came to me and I'm not sick and you said, I want you to take this. I want you to take 7 tablets once a week and give it to your child. And I'm not going to be happy as a mother. So you have to convince me. Now, the trouble is that in the health system at the moment, usually we don't have enough counselors to talk to the people who are not sick. We have communication with people who are sick. We don't have communication with people who are not sick. And finding a way to communicate with them effectively is very important. I can also say, who is the gatekeeper? The gatekeeper for treatment in many families is not the mother. It is often the mother-in-law or the father-in-law. And the Indian Family Planning Program understood this a long time ago, and they said, I'm not going to talk to the wife because she has no power. Who has power in the family to make that decision? And we have to start thinking from an anthropological perspective. These are people. And again, this comes down to research. How do we research? How do we think about research? How do we understand attitudes of people? And how do we change attitudes is another very important research area. Thank you, Ibu. Thank you for the questions.
Thank you very much, Dr. Sharma. Thank you very much. If I can take note from Dr. Sharma's presentation, TB is the leading cause of death and drug resistance from TB part as public health threat, a new public health threat. TB research and innovation is essential to achieve the global target, and also we need to find a new diagnostic treatment and vaccine to support country effort. And also we need to improve policy and practice. Once again, give applause to Dr. Sharma. Okay, thank you very much. Here. Okay. Now we come to the end of the sessions. As a moderator here, I apologize if something makes you uncomfortable during this section. And thank you very much, Dr. Artawan, choosing me as a moderator. And I will give back this session.